So allow me to switch topic and talk about other sleep disorders that are common in older adults. First is circadian rhythm disorders, which are common in later life. They can be disruptive to social and physical activity. Clients will miss appointments. They will miss social events. They might not be able to engage in physical activity or physical therapy if needed. And there are multiple types of circadian rhythm disorders, including advanced sleep phase, delayed sleep phase, biphasic sleep patterns, and irregular sleep patterns. Unfortunately, none of the medication that we had discussed helps with circadian rhythm disorders, and the treatment option that we have to date is using a sleep diary and CBTI. Now, this option can be challenging if there is comorbid cognitive impairment. Next is obstructive sleep apnea, which is quite common in older adults, up to 56% of them, and it increases with age. Muscles of the upper airway relax during sleep, causing the soft tissue to block the airway, leading eventually to apnea. Most relevant risk factors that we know are obesity and increased neck size. Fat in the upper airway or the parapharyngeal fat pads are the main culprits that block the airway. In non-obese patients, craniofacial risk factors are more involved. And an overnight polysomnogram is the gold standard for diagnosis. So the management of obstructive sleep apnea involves clinical screening using the Stop-Bank scale. The most widely used one, translated in 22 languages, has a high sensitivity depending on the severity. And here's the stratification of the risk. The next one is the Epworth Sleepiness Scale that is also used in clinical settings. Now, the other part of management is treatment, using the continuous positive airway pressure, weight loss, oral appliances, and sometimes oral airway surgery is indicated. To this date, no pharmacological agent has proven to be sufficiently effective to warrant the replacement of these therapies. Many trials have been involved and none of them gave favorable outcomes. Modafinil or armodafinil may help with excessive sleepiness, but they do not help with the apnea. The AASM does not support the use of medical cannabis. Restless leg syndrome is going to be the last disorder I'm going to discuss in this module. It occurs in 10 to 35% of individuals above 65. It presents in many ways and shapes. I'm going to discuss a few of them. So it can present with symptoms that are worse at night. It presents with difficulty falling asleep because of an urge to move the legs. It may present with waking up at night with a sensation that the legs are on fire. It may present with a feeling of itching in the legs. It may present with a sensation that they might describe just as funny, but it improves with walking, stretching, and other movements. It can also present with difficulty finding a position of comfort in bed at night in the absence of pain. So the mechanism of restless leg syndrome is not well understood. Multiple etiologies have been proposed. One of them may be low cerebral iron levels, maybe diabetes, maybe end-stage renal disease. Medications can cause them, including antidepressants, antipsychotics, antihistamines, and dopamine antagonists. They cause a higher risk of depression, and they cause a higher risk of suicide in older adults. So how can we treat restless leg syndrome? We can try multiple options, like iron supplementation, with or without deficiency. We should stop the offending agent, treat the underlying cause. We should treat any comorbid conditions like obstructive sleep apnea and insomnia. You can also try behavioral activation and relaxation at night, which helps with mild restless leg syndrome. There are also pharmacological options including dopamine agonists, low-dose clonazepam, and gabapentin and pregabalin. And if all these lines fail, you should refer the client to a sleep specialist. So that concludes our module for today. Just give me a few moments to go over commercial sleep technologies that can also be helpful for our older adults. So what are commercial sleep technologies? These are defined by the AASM as a non-prescription device directly marketed to consumers that may make an assertion to perform sleep monitoring, tracking, or sleep-related interventions. The AASM stands towards them that they lack enough scientific validation, they are not cleared by the FDA, they cannot substitute a medical evaluation. However, they can help you to enhance clinician-patient relationship. Some of the benefits of using them include help with sleep induction, self-care. It's a form of entertainment and socialization. It can be personalized, and it can be a useful source of helpful education, and it can also help with data gathering and sharing with your providers. Examples of these CSTs include mobile device apps, wearable devices, embedded devices, internet resources, and accessory appliances. Keep in mind that older adults will surprise you. Many of them have embraced these technologies and are using them to improve the quality of their sleep. However, they could still use your help and your guidance with using some of these options. Thank you so much for listening to me today, and I hope this module is helpful.